concerns for testosterone therapy and prostate cancer really came from the 1940s, wherein men who had prostate cancer, when their testosterone was removed, were basically given medications or orchiectomies were performed, their prostate cancer went away. Mm-hmm. And so people thought that if you took testosterone away and your prostate cancer went away, the opposite must also be true, wherein if you gave testosterone, your prostate cancer is going to come back. Right. And of course, the Women's Health Initiative that came out in early 2000s with the whole estrogen causing breast cancer didn't help any of this cause, because somehow estrogen breast cancer got associated with testosterone and prostate cancer. But ever since 2000, I think every study that has been looked at, either for testosterone therapy to increase PSA, yes or no, it hasn't. PSA does not really change with given testosterone therapy. Whether giving testosterone therapy in men who've been treated for prostate cancer, like if they're after they've undergone prostate surgery and now their PSA levels are undetectable, you give them testosterone therapy, their risk of having prostate cancer recurrence does not go up either. And so really every study thereafter has really shown that testosterone therapy is fairly safe for prostate cancer. In men who have family histories of prostate cancer, just aggressive screening is important. But I'm yet
or monitoring.
Yes, exactly. But truly, just testosterone therapy is going to cause prostate cancer. I think finally we are over that hump, wherein we don't think that it causes it. Obviously, the AUA guidelines and the Endocrine Society guidelines recommend that we check PSAs every 4 months in guys after starting testosterone therapy above the age of 40.
Of course.
And then beyond that, I think we can sort of put that topic to rest, and we shouldn't be always telling people that testosterone therapy causes prostate cancer.
Right. So believe it or not, we still get so many patients who, when they come to us and they go to their primary or their doctors, and they're like, this is going to give you prostate cancer. And I'm like, my God, I wish, the studies are out there. And it's funny, when I started researching this, so this was Huggins, right, in 1941, that did that study.
Got the Nobel Prize.
Based on 3 people, and he got a Nobel Prize. So I went to med school, UM, the 90s. Every question, every time there was a board question, there was always testosterone and prostate cancer. We knew it was a no-no. So confirmation bias, it's hard for physicians to unlearn what they've learned. So we need to really, so that's why we're doing this. So that when a patient tells us that, we can unequivocally say that testosterone, with all the studies that we have, does not cause prostate cancer. And one thing that was interesting to me, that was based on that one study. There's never been one study that showed harm. None. None that showed that testosterone was associated with prostate cancer.
Absolutely and one of them, from the study, one was castrated, if I believe, the other one was healthy, and the other one had a metastatic prostate cancer.
Correct.
So he won a Nobel Prize, so people didn't want to question by the time. And then how many HRT clinics were back then? Nobody really questioned it. So if he said it, nobody questioned it. Because of that, till today, that's being used.
I heard a statement that to me was very valuable. That that it said that at some point, 1 out of 6 men will contract some form of prostate cancer.
That's correct.
Right now, one thing is to die with prostate cancer rather than dying from prostate cancer. Right. So. That's an important distinction.
Well, Dr. Morgenthaler, I know you do a lot of studies with him. He said that. He said in the beginning, when he started giving patients testosterone, he was doing biopsies. And he said he discovered so many patients with mild, low-grade prostate cancer. So it's like, for patients doing testosterone replacement, it's like you are giving some patients who have undiagnosed prostate cancer. And we don't see an increase in prostate cancer on those patients who give testosterone. But there's no questions. We monitor PSA regularly. We do it 2 months after we start, then 2 to 3 times a year.
And you do the percentage as well, right?
No, but we do the PSA. If it's above 4, we do a percent-free PSA. And if we see a big increase, we will refer. So there is the saturation hypothesis. And I see that. When a patient comes with a testosterone level less than 250, you will see an increase in his PSA. Usually 0.5, 1 point. So we can see that, but it doesn't worry us. But we keep an eye on it. Another point on testosterone, the prostate.
And if I may, can you just kind of explain the saturation model? Because I think that's really important for our viewers to understand what the saturation model is.
I'll let you guys do it.
So androgen receptor is the receptor on which testosterone binds to. Testosterone binds to it free testosterone binds to it, dihydrotestosterone binds to it, just same androgen receptor. So let's say the prostate has about 100 receptors to which testosterone can bind to.
Right.
And a serum testosterone level of around, we think it's around 150 to 200. At that level, all of the 100 receptors are bound.
Right.
And so increasing a guy from a level of 215 to 415 is not going to do anything more to his prostate because all of that 100 receptors are already
taken out
bound.
completely.
And so
saturated.
so like for example, and Dr. Morgenthaler uses this in all his talks, is if you have two guys with prostate cancer, actively diagnosed prostate cancer, one has a testosterone level of 650 and the other one has a level of 250, you don't bring that 650 guy down to 250 because you're scared his cancer is going to come back.
Right.
You'll leave him alone.
Yeah.
Whereas with a 250 guy, you're so scared to bring him up to 650 because you think cancer is going to come back.
Right.
And so really that's a fascinating story in saturation hypothesis. And I think he's done a lot of work.
Yes.
And there's a very nice study that came out in 2005 out of UCLA by Lenny Marks, where they basically biopsied the prostate both before and after giving testosterone therapy at 6 months. And they found that the levels of testosterone within the prostate are just the exact same, whereas the serum levels went up.
Wow.
Amazing.
Both testosterone and dihydrotestosterone did not change within the actual tissue. So this whole concept of like, oh my gosh, my level's going to go up, and so therefore the prostate is going to see more testosterone, therefore the cancer is going to go up, I think it's really, really unfounded.
So this thing that it's pouring gasoline onto a fire that we all say, we can put that to rest.
Yes, I think so. I think you can put that to rest. Really, the pouring gasoline on fire is someone who's actively diagnosed prostate cancer.
Yes.
That's high risk disease. That's possibly metastatic. I think giving them testosterone therapy without treating the underlying cancer, I
That
think
is
that's
gasoline.
wrong.
Of course.
That's gasoline on fire. But I think that's a very small population of patients compared to.
And
the
if they
majority
got their
of patients.
prostate under control, meaning that they did a
I think it's safe to treat. After surgery, I usually wait for 3 months.
Yeah.
And if their PSA is undetectable, I give them testosterone therapy. And then after radiation, it's a little bit of a challenge because the PSA can go up and down. So I usually wait about 2 years until their hormonal treatments are done, and then I start.
But this is where we like to associate
Yes,
ourselves with somebody
yes,
like you.
yes,
If you
yes.
have patients with prostate cancer,
Yeah.
you'll take care of them. Now, staying
the
on the
complicated
prostate.
ones, that
Yeah,
one's.
I gotta
You're gonna have them all.
touch this. Now, staying on the prostate, incidence of LUTs, lower urinary tract symptoms,
right.
BPH, worsening, voiding urine
Yep.
problems. I've heard a urologist told that to my patient. They're like, if you take testosterone, your prostate is going to blow up and explode. Like, what? So the studies now are pretty good
Yep.
that there's no increase in lower urinary tract symptoms with testosterone therapy.
Correct. That's correct. I think we actually did a meta-analysis which we published a few years ago, where we showed that patients who have mild to moderate symptoms of LUTs, wherein they wake up a few times to go to the bathroom, but they're not bothered by it, and they're taking medications and they're controlled, we've showed that testosterone therapy doesn't worsen their LUTs. Whereas in patients with severe LUTs, which we've never given testosterone therapy to, that's why we don't know what happens to them. Like severe obstructive urinary symptoms where they have retention, where they have issues with forming kidney stones or bladder stones, blood in the urine, all those symptoms, giving them testosterone, we just don't know because we've never given it. But I think there it's probably the wrong thing to do to give testosterone. But in patients with mild to moderate lower urinary tract symptoms, I think it's completely safe.
Very good. So, prostate health and testosterone, we just dispelled a lot of myths.
A lot of myths.
Thank you.
Thank you.
Now, the other one, testosterone in the heart and heart attacks, cardiovascular health. Because unfortunately, there's still a black box warning on testosterone supplements that once your patient gets that, it says, the FDA says that testosterone may increase your risk of heart attacks and cardiovascular disease. Let's talk about this.
Absolutely. So the fears for testosterone therapy and cardiovascular risk really came from two studies. One was initially published in 2010, where they gave old, frail people in the nursing home very high doses of testosterone gel. And they basically looked at cardiovascular events at 6 months, and they found even simple things like changes in EKG, hypertension, which could all happen pretty commonly in elderly people were higher. And they halted the study soon and said, oh my gosh, cardiovascular risk in this older population is pretty bad. And then came another VA study where they looked at people who were undergoing angiograms after getting testosterone therapy, and they found that the risk of heart attacks in that population was higher. But really, that population was also very sick, and some women were included into the study by mistake. And so there was lots of flaws with the study, but that's what basically prompted the FDA to go back and look at all of this evidence and say, we now need this black box warning.
Wait, there was women in, it was a men's study and some women got
Some
And you
women.
can assume that a lot of these people had metabolic syndrome also.
Yeah, correct.
Which
But
is-
women were not given testosterone therapy. It just got included by mistake. And
But
one
that's
of the
how bad the study
Right,
was.
that's
They
But
included
listen,
women.
it got published in JAMA, which is like one of the
Wow.
biggest medical journals that we all read. So whatever. Regardless. But that's what prompted the FDA to look at this closely and come up with a black box warning. But if you truly look at the AUA guidelines, it actually says it does not cause an increased cardiovascular risk. In fact, it has shown to improve atherosclerosis parameters. The one thing that does happen is HDL does go down in men with testosterone therapy, but the LDL and the total cholesterol remain the same. So I sort of warn patients. Yes, correct.
Decrease.
But that's the only one thing that I warn patients if they need to exercise and stay on top of that. But beyond that, really, I've not seen too many risk factors. I do advise patients, we all document it in all our charts because it's an FDA warning. I tell them there's an increased risk of stroke, heart attack, and pulmonary embolism and DVT, but I tell them no studies have actually shown a direct association. And number of patients that have listened to all of those risks and told me no, they don't want testosterone is probably a big zero.
Yes.
And so,
So
it is
again,
documented.
we did a review of the 2018 international consensus from the Mayo Clinic.
Correct.
Because that was important to us.
Yeah.
And the Mayo Clinic, we know they're reputable. And they say, again, there
No
was
evidence.
consensus agreement that testosterone therapy does not increase the risk of heart disease. Once they reviewed all of those studies.
Right.
So as you said, there were 4 studies that showed possible adverse cardiovascular events.
Right.
All the other studies did not. And the testosterone trials,
Right.
that big testosterone trials that they
Yeah.
did not show any increase of heart disease. So this was, forgot how many men, it was 7
7
trials,
Yep.
right, that they looked at
790.
all those men. And they did not show an increase in major adverse cardiovascular events. That was important to me.
Correct.
It did show a mild increase in non-calcified plaque.
Correct.
So some cardiologists that I spoke to are like, well, it showed that. We're not sure, but nothing changed. But overall, and another statement that we can say confidently is that low testosterone deficiency is an independent risk factor for all adverse cardiovascular events.
Correct.
Is that correct?
That's also correct. Yes, Molly Shore's one of these studies that came out of the Seattle VA actually showed that in men who had low testosterone actually died sooner compared to men who did not have low testosterone or normal T levels, and they were untreated men. Both cardiovascular mortality and just overall mortality. And so a lot of guys come and ask me, Doc, my testosterone's low. Do you need to treat this or should we just leave it alone? And I have to tell them that study and I have to state that risk, that low T is an independent risk factor for cardiovascular mortality. So do something to increase that T level, right? On your own, if you can lose weight, exercise, sleep better, and improve your habits and increase the T level, then maybe you won't fall into that risk category. But if you're just going to leave that level like this and not do anything about it, you do have a risk of cardiovascular mortality.
That was really important to me when I saw that, because we give a lot. We have 1,200 men now on testosterone. By the way, 50% of them are 40 or less.
47%.
Yeah, you said that.
Yeah,
Yeah.
that's crazy.
Yeah.
But it made me realize that I know testosterone is a performance enhancing drug.
Right.
So they feel better, they look better, they have better sex. But for me, the MD, once I saw that I was changing their health, that I'm putting them from a high risk of heart disease with low T versus a lower risk. So not only do you feel better, look better, and have all this, your health is also better.
Right.
Your bones are stronger. There's even like some studies now with prevention of Alzheimer's dementia, maintenance of cognitive function as we get older.
Right.
So there's so many things. So cardiovascular disease, we can put that to rest.
Right.
We still need longer studies.
Yeah.
But as what we have right now,
Yeah.
there's first, testosterone deficiency or low T is an independent risk factor for cardiovascular disease.
Right.
And there's no evidence that replacing testosterone therapy increases risk of heart disease.
Right.
Very good. And prostate. Right? Didn't you tell me there was a study that showed that, and maybe, Doc, you know more, that there was a study that actually low testosterone or testosterone deficiency caused more aggressive forms of prostate cancer?
That's correct. Yes. So we talked about it a little bit. If their testosterone levels are low, their PSA levels could be low by itself, because remember, of the 100 receptors, if only 50 of them are bound because their T level is low to begin with, then your PSA is going to be low, although cancer inside is growing.
Wow.
And so if the PSA is not going to be produced, we're not going to be able to detect it faster.
Right.
And so if you truly have a low T level, sometimes that underlying prostate cancer could be masked because your PSA is going to come back, quote, normal.
Right.
And you're never going to pick it up for a long time because your PSA is not going
So
to
then the problem is that you'll catch it, but you'll catch it in stage 4.
That's correct.
Right? Rather than catching it at stage 1.
Way more advanced,
Wow.
yes.
That's incredible.
Well, kind of to bring that around, because as he said, testosterone is a performance enhancement drug, right? In reality, we prescribe to exercise because it does enhance the performance of the body for the better, meaning it does improve endothelial function, improves absolutely specifically is an insulin regulator, right? The more muscle you have, and I'm not saying to become a bodybuilder or anything, just to have more muscle mass so you don't suffer from sarcopenia, and to strengthen the bones, you need to put some resistance on the structure, right? Yeah. So you can't strengthen, your bones, your body strength is tied to the strength of your bones. So this is why we think that exercise is literally part of the prescription. We literally put it, well, the doctor literally puts it on the prescription because it's very important to exercise.
Well, and to kind of echo that, you know, we were talking about, you know, the person's like, oh, I just don't have the motivation or I don't have the energy. But going further, somebody might make the actual effort, this Herculean effort to get to the gym, and then they work out, and then the recovery, it's, you know, they want to die for 3 days because they can't recover. Right? So they're like, I'm never doing that again. Right? So it's kind of like a...
to your point, strength is one of the independent predictors of mortality also. So as you get older, what happens, you lose muscle, sarcopenia, a lot do because of low T, and they did studies that the lower your strength, they did mostly grip strength, and they showed that the lower your grip strength, the weaker your grip strength, the higher your risk of mortality. So again, we're making people feel better, look better, be stronger, not just for looks, it's to protect their health.